Hello, everyone, and welcome to our third webinar in the session of Relocate. Sorry, a second here. I can't see. Sorry, just everyone, just a second. Position. Okay, hello, everyone, and welcome to our third webinar on the built environment during the pandemic crisis. My name is Michael Stevens. I am responsible for communication in Ramboll buildings. I will try to guide you through the day without too many sort of technical glitches and facilitate it. I have a couple of people who will be helping me along the way. Today we have 4 speakers. First we have, thank you, just a second. First we have Amy Scho from Mass Design, who will present a case from the US on how the hospital there has fared. Afterwards, we'll have Birgitte Gade from Arkitekter, who will sort of talk about the learning from the Scandinavian hospitals. Then we have Annette Pilosov from Cambridge University, who will share some experiences from telemedicine usage in Israel. And at the end, we will have Eduardo Chileiro Teran from Cinque Arquitectos, who will share some experience from Spain. Sorry for the pronunciation. It's not always that easy with all these different names, but it shows how broad it is, the picture we're trying to get here together. We aim to have 15 minutes of presentation from each presenter. Afterwards, we would like to have some time for questions and answers. And to do that, I would like you all to use the questions pane, the chat box, where we will sort of monitor what kind of questions come in. Everyone will be muted at first, but you can ask all the questions you want during the session. We'll try to sort of bundle them together and get through all of them. If not right after the presentation, then at the end, hopefully. Or finally, maybe if we don't manage to get it, we'll try and sort of see if we can follow up afterwards if there's some really interesting questions. We will record this session and we will then share it with everyone who signed up. So please be on your best behavior, all of you. And before we get started, I just wanted to guide you through a few ground rules. Just a second here, I will share my screen. Can you see my screen now, everyone? There we go. You should be able to see my screen, and this is just some basic, sorry. So basically, you will all be muted. We can't see your camera. We can't see your face. There will be no questions. As I mentioned, we will then also, during the session, we will also ask for your feedback. We want to have it a bit interactive, and we will use this called Mentimeter. So, and just to test it, you'll be able to sort of get some insights on who is looking into this and what they think of it. And if you look into it, we have this polling system called Mentimeter. Sorry, darn. Sorry for the technical difficulties here. Let me just see if we can do it here instead. So if you all can go to Mentimeter. Sorry, I think we might have gotten news. Sorry, I'm not sure if I can log in. Okay, anyway, there seems to be some problem with the interactive polling, so we'll get that sorted along the way. This was first or second, just for testing. In any case, what we would like to do, we would basically ask you to sort of take out your phone when it comes to the end, and then I will try to sort it out in the meanwhile while we have some people presenting. But before we get started, or once we get started, I would like to start with Flemming Schmidt, my colleague from Ramboll Hospitals, and Saga Carlson from White Architects, who will sort of introduce the project, what it is, the purpose of the Relocate, Repurpose, and Reorganize session is. And I will just go over to you now. Let's see, there we go. Flemming, I think the floor is yours.
Thank you very much, Michael. Yeah, as Michael said, my name is Flemming Schmidt. I'm the Global Market Director in hospitals in Ramboll. And I sort of started this initiative up. And if you go to the next slide, Michael, I will give you a brief introduction of how it really started. Back in March, when the pandemic started to pick up and everybody was running around, knocking on doors, trying to help out locally, we sat down and thought we really wanted to make some kind of a different initiative that would be of a more international scale. And in this, I started to discuss how to do this both internally, but also with Walker Project and EU HPN, Jonathan, who both helped out in maturing this idea. And the overall idea was basically trying to make some kind of a guideline to prepare and to build facilities for the pandemic. And Michael, if you go to the next slide, I'll just say a few words on how this organization is or project is built. We are like 4 parties in this. The EU HPN Walker Project was the initial one, but white architects approached us and said, "Hey, this is a great initiative. We would like to join in on the team." And since we really needed different perspectives and approaches to clients, hospitals, and the general environment, we really thought this would be a really good and diverse project team for this. The funding for the project is given by the Ramboll Foundation, who supports society initiatives. So this is basically or completely a non-profit initiative, sorry. And this is what we are trying to focus on. And Michael, if you turn to the next slide, talking about the goals of this project. The overall goal is to create a platform for sharing knowledge of the COVID-19 and to do it with a strong focus on resilience. And this is basically what the idea is built around. To go more into details about it, it's to compare and contrast the different strategies used across the globe, or internationally at least, to get a deeper understanding of the choices who's been taken and to derive common elements of success factors in this. And not least to advance research and exchange in terms of standardization of the pandemic care units. If you turn to the next slide, Michael, talking about resilience, we've been trying to really frame this resilience into some parts of it, and you can just pop through this one. It needs to be filled out. Resilience to us is divided into 4 major. Oh, that's one too much. 4 major areas around staff, around systems, around space, and around supply chains. And that's basically, as we see it, what's covering all of the resilience needed for hospitals, and especially compared to the situation we are in right now. That said, if you go to the next slide, Michael, right now we are at the 3rd webinar on this, and aiming for the 4th one in November. And as you can see at the headlines here, we are at this one focusing on space from the resilience part, and the next one will be on healthcare ecosystems. That said, I will hand over to Saga, who will tell a little about the results of the project. Saga?
Thank you, Flemming. I will continue to talk a little bit about the result of the project, but before, I just want to introduce myself. My name is Saga Karlsson, and I'm the Head of Research and Development for Healthcare Building at White Architects. I've been working with healthcare architects for almost 10 years now. And I think long before the pandemic came, this has been one of my interests in looking into how architects have dealt with changes in healthcare building. And last year, I actually finished my licensing thesis focused on future-proofing approaches in healthcare building. So with that said, I'm very much looking forward to listen to our speakers today. But well, that's about me. Our goal in this project, or the result, is to publish a field guide with learnings from real cases, and a field guide that can help stakeholders with decision within the topic that we are studying. It is also a framework for planning and action. And our stakeholders are senior hospital managers and directors, board members of hospitals, hospital planners, architects and engineers, policymakers or politicians involved in the pandemic response. But one can also add policy analysts, and I would like to, in this list, also add maybe academians that could be interested in this. In the field guide, we will focus on the challenge and context, processes to the solution and the solution itself and its effect and outcomes. So if you could please switch page now, Michael. Our ambition is to collect more than 40 case studies, predominantly from Europe. But if we find interesting examples, I think, for example, the case that Mas will show today, we have said within the group that we will allow them into the field guide as well. Because as a result, the field guide will be published on an interactive web page, and as more cases that we can have, as better, I think it is. So the interactive web page will show the field guide, but also the different cases and the presentations from our webinars. So if you missed one of the webinars that we had before, you can always go into the web page when it's finished. Could you please change slides, Michael? But in order to finish this practice-based research project, we are now asking for your help. If you have a project or a case that you think might be interesting for us, please contact any of us and we will submit it for you. If you're interested to be part of the peer review group when this is almost finished, you could also contact us. You're very welcome to do so. Could you please change slide, Michael? And now for today's focus, I have to start to say that I heard most of today's speakers in other forum, and we are very happy to present these excellent speakers here today. When inviting the speakers, we have asked them to answering following questions. So we have asked them to respond to how the built environment has been dealing with the architecture, with the hospital itself, and how it have dealt with the pandemic cases. So if we can please take the next slide. There, the question came. Thank you. And how were the clinical and non-clinical spaces done, and associated logistic and technical solutions? How they were relocated, repurposed, or reorganized, and the keys to success and the barriers of it, and the lessons for the future. So I hope our speakers will be able to talk about this today, and I hope you in the audience have a lot of questions to them. So let's start with the first speaker. Thank you.
Thank you, Saga. Amy, I will make you a presenter. We'll start with Amy from New York, as mentioned before. Amy, you should be able to get the screen now. Can we see you? And Amy, if you can also, there you go.
Can you hear me?
We can hear you and we can see you.
Excellent. You can see my screen, right? Okay, great.
We can see your screen.
Well, thank you so much for having me here today. My name is Amy Shao. I am a principal with Mass Design Group, and I'm joining you actually from Kigali, Rwanda. Back in March, on March 27th, actually, we received a call from a couple of doctors at Mount Sinai Hospital, which was at the epicenter of the New York City pandemic. And at that point, COVID was still a very new thing to all of us. Healthcare systems were scrambling to set up policies and procedures and find PPE and mobilize staff and prepare for what we knew was coming, a surge. but it was already very apparent that healthcare workers were in an extremely vulnerable role. At that point in late March, more than 62,000 healthcare workers across the US had already contracted COVID, and at least 290 had already died. And what you just mentioned, staff, systems, and supply chains were being addressed, but space, this was very early on, and space wasn't yet being looked at. So we wanted to see whether there were ways that the physical environment of COVID care units could be tweaked or changed to lower infection risk to healthcare workers. The team that we set up was a group of clinicians and designers with really diverse experience. We had doctors from Mount Sinai Hospital, a world-renowned medical center at the epicenter of the US pandemic, architects and design researchers from my firm, Mass Design Group, which is a nonprofit. We've spent the last 12 years designing healthcare facilities all over the world with a particular emphasis on infection control, as well as doctors and researchers from Ariadne Labs, Joint Health System Innovation Center, founded by Dr. Atul Gawande. So beyond leveraging the vast experience and perspective of our clinical partners, we built upon our own experience designing against epidemics, combined with the work that we've been doing around novel research connecting space and outcomes. So, MASS was actually founded 10 years ago in response to an infectious disease, extremely drug-resistant tuberculosis, which was being spread in crowded hospital wards and waiting areas in limited resource settings. So our first project was the design of a district hospital in rural Rwanda for Partners in Health, and the Ministry of Health that was fundamentally designed around air. The massing of the hospital, rather than do a big multi-story hospital, we broke it up and had smaller volumes that sought to eliminate double-loaded corridors entirely, and we were able to leverage the temperate climate of Rwanda to do so. And inside, we inverted the layout of the wards so that we could maximize natural and cross ventilation, and then also we're able to integrate high volume, low speed fans, which aren't shown here, as well as ultraviolet germicidal irradiation on the top plenum of the buildings. In Haiti, we designed a hospital specifically for multi-drug resistant patients for our partner Geskio, and here around a central courtyard, we wrapped isolation rooms that were laid out to reduce the exposure of medical and cleaning staff to potentially contaminated air. We'd also built a cholera treatment center in Haiti, which is a waterborne disease which broke out there after the 2010 earthquake, as many of you I'm sure are aware of. And we built an underground wastewater treatment system to clean and filter the water and ultimately stop the cycle of reinfection that was coming up from treatment facilities. And the design of the space itself sought to bring light and air and greenery into an otherwise very miserable and undignifying disease. And then in Liberia, after the Ebola outbreak, we worked with the government to build a 250-bed hospital, which was designed not only around air and water, but around rebuilding the public's trust in the health system. So beyond those design projects, we'd also been developing spatial research methods, which were trying to look at how we can connect space and outcomes. We'd work with Ariadne Labs with funding from the Robert Wood Johnson Foundation on a year-long project aimed at looking at whether the layout of labor and delivery units was actually affecting the rate of unnecessary C-sections. And as you know, most evidence-based studies in healthcare look at the scale of the room or kind of elements that are very definable. But we were interested in the system forces that are affecting how clinicians make care decisions. So we were looking at the maternity unit as a whole. We visited and collected data on case studies across the country, and we engaged clinicians to help us visualize the care processes that were going on. And that ultimately allowed us to generate testable hypotheses that linked healthcare space design measurements to C-section rates. And we were able to publish the results of our work in some peer-reviewed journals, which we were really excited about. So that was all the background, that was the foundation. And So in early March, when COVID was emerging, we'd begun developing some general resources for spatial thinking related to COVID infection control. So when we got that call from Mount Sinai, we were able to start very quickly. And what we recognized was that there were many hospitals that were implementing spatial redesigns on the fly without much guidance to prepare for the COVID-19 surge. So what we wanted to do was capture quick interventions that were working and share lessons to assist other facilities on how they could be more informed in moving forward. So what we did together was document how spaces were being adapted by developing quick and nimble approaches to research and collaboration. So the question that we had to grapple with was, what does evidence and research look like when we're moving so quickly and without much guidance? We couldn't apply the methods that we normally would, which would be clinician shadowing, holding workshops, running simulations ourselves to see how care processes work. In those early months of COVID, as Nicholas Kristof reported in the New York Times, it had been easier to be embedded in army units in Iraq or Afghanistan than to embed with doctors fighting COVID at that point. So our research study lasted 3 weeks, and it was a rapid response spatial research method that employed a lot of different types of approaches. So over Zoom, the doctors led us on virtual walkthroughs of active COVID care units, and we had to really carefully outline what we wanted to see and have them do practice run-throughs on non-active floors ahead of time in order to optimize their time on the COVID floors and keep them safe and also not impede the care processes. And then using GoPros strapped to their chest, they also captured time-lapse footage of COVID ICUs, which allowed us to go in and later look closer into the photos of what was going on. We ran a series of interviews with facilities teams and clinical operations teams, people who were putting these changes into place. And then we worked with clinicians to have them also annotate floor plans to visualize how the spaces were being used. Let me just go back to this for a second. So I think from a personal standpoint, it was a really incredible and surreal experience. As I mentioned, I'm located in Rwanda. So due to the time difference, physically, I was sitting on nighttime calls in my kitchen, slapping mosquitoes away, and virtually I was touring busy intensive care units in New York City. I think this type of collaboration across geographies, across time zones, across disciplines was really incredible and felt very urgent and of the moment. And what we saw on those phone calls was some really unprecedented spatial change. And we saw a lot of critical care taking place beyond the normal confines of the patient room. So at that point in mid-March, Mount Sinai had already begun really radically transforming its care delivery system. They changed their main atrium, their main lobby here, into a 100-bed step-down unit. And then they built a temporary 68-bed tent facility across the street from them in Central Park. And then within their existing ICUs and med-surg units, they transformed 260 existing patient rooms, normal patient rooms, into negative pressure isolation rooms. So for this example, in this ICU, the openings had previously been open, and so they constructed walls and doors across those fronts of the bays. They brought in large HEPA filtration units and set them up to directly exhaust outside of custom fit wood panels that were installed in the windows. And the change at which these things took place was really radical. Here's a before and after of just one floor of the hospital showing how 3 intensive care units were converted. And the buildings themselves were literally intubated to expel contaminated air. I would pause for a moment to recognize the uniqueness of this floor plan, which was designed decades ago by I.M. Pei's firm. So it was an honor to be looking at such a historic piece of architecture. So what we quickly grabbed onto was that the in-between spaces were really critical. You know, a lot of attention was being paid to the patient rooms themselves, how to make them negative pressure. But all of these hallways were really where we wanted to address risk. In order to minimize clinician exposure in patient rooms while still allowing for that really high acuity care to happen, these double-loaded corridors suddenly became the do-everything space. They accommodated IV poles, as you see here. They accommodated patient monitors, PPE stations, waste receptacles, staff workstations, clinician rounding, and a lot of the care processes that had previously taken place in patient rooms were now happening in the corridors. Many of them, as you can see here, were already narrow, particularly in an urban environment with older infrastructure that was limited. But when crowded with all of this equipment, as well as teams working and making rounds, this didn't create the safest conditions for healthcare workers. And we recognized really quickly that enforcing proper infection control protocols in corridors and key thresholds like unit entrances was just as important as in the patient rooms. So in the end, we looked at 3 different COVID-19 units: an ICU, that was an adult one, adult medical unit, and then a pediatric unit. And we found that amidst the really heroic efforts to transform hospital-wide clinical processes and infrastructure, there were a lot of adaptations that varied between floors and between units. And between or within adult ICU units, it wasn't possible to integrate antechambers or changing areas due to the spatial constraints of the floor plan and the need to maintain direct visibility right into the patient rooms. In one unit, as you can see here in the upper right image, colored tape was used to try to delineate the threshold in front of patient rooms and demarcate contaminated zones. But specific areas for where you should don and where you should doff were not delineated, and the system wasn't super clear and it wasn't applied to other units. This was a kind of a test one. We did see a lot of innovative design hacks that were implemented by both the hospital and the clinicians, which were innovative, but also revealed some implementation gaps and confusing variability between units, like informational signage or the way that individual face masks for doctors were being stored, as you see in the brown bag system here. So what we learned from this initial study over 3 weeks was the notion that spatial literacy, which basically means like how one reads and perceives space, can be leveraged to keep people safer. So when we were engaging with the hospital clinical staff, we saw really big differences in personal perception of risk zones within care units. So one of the things that we did was ask clinicians to create what we called risk heat maps. We had them color code printed floor plans using red for the hot, in the clinical terminology, hot or risky areas, green for clean or safe areas, and orange for areas that were somewhere in between, areas with potential infection risk. And as you can see here, 3 different clinicians drew completely different maps and had completely different perceptions of what is essentially the same unit, reinforcing our observation that spatial literacy not only has, it has really direct implication on the interpretation of donning and doffing protocols and affects not only what level of PPE clinicians need to put on, but where they do it. So in the rush to expand bed and caregiving capacity, hospitals hadn't yet been able to have the time or the energy to develop the human-centered design cues to communicate key information and enforce adherence to protocols and create order and confidence. And because staff responding to surge conditions are often redeployed and assigned to work in unfamiliar environments with new team members, like imagine yourself coming to a new space for the first time with people who are fully gowned up, you can't tell who they are, you don't know them. Visual aids and design nudges, even things as simple as paint or tape on the floor, can help to lower infection transmission by making invisible risks more visible and orienting people and creating spaces that instill confidence and collaboration. So we mentioned that this is a research project, and ultimately the lessons that we took away from those 3 weeks were that first, time is of the essence, and as designers, we need to be able to mobilize really quickly and collaborate deeply and leverage nimble research methods to respond in situations that are unpredictable and constrained and out of our control. And we also acknowledge that, perhaps more than ever, space has a really vital role to play. The physical environment shapes how people behave, how they interact, how they make decisions, and spatial literacy and design cues are key to indicating risk and standardizing behavior to keep people safe. So after collaborating with Mount Sinai, we published a report of our research, which is now on our website, and we went on to develop other COVID design resources, including design recommendations for, this one's for senior housing. We also did it for hotels. This one's for restaurants. We also did it for museums and schools and even prisons. And, now our team is working to put together a learning collaborative of multiple health systems. We want to look at a broad range of facility types and geographic contexts in different moments of the kind of wax and wane of the pandemic. We want to expand to look at a broader set of care delivery spaces, not just dedicated COVID care units. We want to look at a broader definition of safety beyond infection control, but also things like communication and morale and stress management, and for all healthcare workers, not just clinicians. And ultimately, we hope to develop clear spatial guidance that can be used globally to transform hospital units in the COVID-19 area. So I think just to conclude, NASA's motto or thesis since its beginning has always been that buildings are never neutral. They either help or they hurt. And as I think we all acknowledge, COVID brought to light a lot of cracks in our systems that were previously less visible. It revealed issues of equity, it revealed how interconnected and interdependent we all are, and it revealed that we need to be designing for health in the largest sense of the word. So I'd say that, on the plus side, it's also created a bigger awareness of the role of the built environment in keeping people safe. There's a lot more discussions in general media and among the public, no matter what community or field of work you're in, and people have an awareness of what spaces you feel comfortable in and the density of those spaces and a tacit understanding of airflow versus stagnancy. And so I hope that we can be optimistic that this will open up a greater appreciation and value for the role of design in all kinds of spaces. So thanks for letting us share today, and look forward to the presentations.
Thank you, Amy, and fantastic presentation. Very on topic and delivered on time, even from my perspective. There's a couple of questions. Saga, will you take them?
Yes. Thank you, Amy, for your presentation. I got a question here from one in the audience. He asked, he said first, this is a fascinating work, but did you have an opportunity to also follow the engineers, technicians, and facility managers during this period? Because you talk a lot about the clinicians.
Yeah, so we did. We didn't have the engineers and technicians. We didn't do the Zoom work with them in terms of the touring because they were not in the active COVID care units at that point, but we did a lot of interviews with them, and I think recognized that it's really important to bring together the viewpoints of all of those various types of folks that are playing different roles in kind of making all of the facets of the space and stuff and systems and I'm forgetting what. Anyways, come together, and the clinical operations team and the facilities teams were working really closely together. So unpacking kind of how they did so well and how they could have done so better, I think will be really important in figuring out what are the best systems for teamwork and communication within hospitals, and how do they bring in collaborators to be able to do this better. And there are so many learnings that they had to share from what were some of the early problems were a lot of were on the procurement side of how they get all of those HEPA units and all of that stuff, and to what degree they are implementing changes that will be very permanent versus very temporary. Nobody knew at that point. So they did the best they could and mobilized really quickly. And I think capturing those lessons was really important as well. Thanks for your question.
Thank you for answering that question. Now we will go to the next speaker, Michael.
Yep, thank you very much, Amy. Birgitte Gade Ernst from Arkitema will present the learnings from Scandinavia. Birgitte, the screen is yours, I hope. Can you? Birgitte, can you hear me? We can't hear you, Birgitte. Can you hear us, Birgitte? Can you unmute?
Thank you, Michael. Is this better? Can you hear me, Michael?
We can hear you.
I think you muted me. That's okay. Right. Thank you, Michael, and thank you, Amy. That was really interesting. Now we'll move to Scandinavia. Good day, everyone. As healthcare architects, when we design, we always begin and end with function. We design our buildings according to the brief. We optimize it in close collaboration with the hospital staff. And then on all of a sudden, what has happened in the current pandemic is that our hospitals are used for something completely different than what they were designed for. So how have the hospitals managed this? And how well have the existing buildings complied to this? And finally, of course, the question is, what can we learn for future designs? Because with SARS, Ebola, and now COVID, there is a general acknowledgement that we must prepare that this situation will happen again. So this is what I'm going to spend the next 15 minutes on, with 2 examples from Danish COVID hospitals and 1 example of how we in Arkitema rethink our current hospital design. Right. My name is Birgitte Gade Ernst. I'm a partner in Arkitema Architects and responsible for our Danish healthcare buildings. And as you can see, we design healthcare buildings in any scale, from new hospitals as the new Children's Hospital in Copenhagen, to life science buildings and healthcare centers. We are Scandinavian, and we have a Scandinavian approach both in our architecture and in the way that we design patient-related design. Right, so first some background information. In the international press, I've read about the Scandinavian response to COVID-19. And I believe there are 2 reasons that the COVID situation is fairly manageable in Denmark. First, our hospitals are national. They're managed by the regions, but it's one system with a large degree of knowledge sharing, which has been useful in this crisis. Secondly, as you probably know, Denmark is a welfare state. That basically means that we accept quite high taxes in order to secure education, law and order, pensions, and indeed healthcare for everyone. So you can say we have a contract with the government that we pay, and in return they take care of the weak in society. That again means that when the Danes have shown this red and green COVID curve, and I explained the importance to avoid the red surge, to keep distance, to work from home, to wash our hands, we do this by and large because it's part of the aspect of taking care of the weak. Also, if we fall ourselves, we are sure of help. So there are mainly two important aspects that we have learned from this pandemic, which is surge and separation. And these are the issues that I will talk about here. The figure on the right, you see in Denmark, we had in March, when it was worst, we had 550 COVID patients only, and today it's 124 at hospital, only 15 in the ICU cares. We have a population of 5.8 million people, so it's fairly manageable, but still we take care. Right. Some of the first to accept COVID patients in Denmark were, of course, the National Hospital, Rigshospitalet in Copenhagen. Here, a new north wing. This is the building at the bottom right with the zigzag motif. It should have been inaugurated, but it was delayed. So the hospital thus had a whole new empty building that could turn into a COVID hospital. So here the topic of separation was solved quite easily. And this is not our building, by the way, it's designed by 3XN and Link architects. Regarding the surge, this has not yet been an issue in Denmark. We were warned by what happened in Italy, and we have prepared accordingly. So Rigshospitalet and other hospitals quite quickly cancelled a number of elective patients, and also more nurses were retrained to handle intensive care patients. So interestingly, none of the Danish hospitals were fit to deal with testing facilities. So in order to secure separation, testing tents were set up all around the country and also here at Rigshospitalet. So inside the new north wing, the specialist in charge, Dr. Jan Bunde, initially thought that the brand new 200 single bedrooms were perfect for the job. Instead, he and his team found out that they were too short of staff to maintain surveillance in the many rooms, and instead they used the operation theatres and the adjoining pre- and post-op and gathered, as you see here, 10 beds in one room. So you have there are 3 rooms with 10 beds on each floor. In the nearby region of Zealand, this building was the main hospital for COVID patients, and this is one of our buildings. It was designed as a mother-child clinic. And as you can see, this is also a building on its own, so connected only with corridors to the main hospital, top left, and the acute care clinic, top right. We have the wards and the quadrangle, and the delivery rooms, etc., in the L-shaped building to the right, directly connected to the acute care. And this is what it looks like today. The tents here are not only used for testing, but they're also used for triage, for observation. And as you can see, the tent construction continues along the right side of the building. So this is the whole tent scape with a whole new organization. The tent ends at the entrance here at the red arrow. This is actually just a back door used for deliveries, and now it's the COVID-19 entrance. Directly to the right of this door is an elevator, and this is now used for COVID patients for separated flow. So this small back door allows a whole new separated flow to this hospital. You have this blue COVID-free zone. In effect, you have a tiny part of the footprint of the building, which is this COVID zone here illustrated in red. And the top floor then is now a dedicated COVID floor. In this region, there's not been such shortages of staff. Reallocation has sufficed. And here the single bedrooms, which is normally for mothers and the newborns, are now used for COVID patients. The single bedrooms have an advantage for the patient, as some of the equipment used for allocating oxygen, etc., actually make quite a lot of noise. So imagine lying there feeling very sick, and it isn't helpful at all to have to listen to a machine that supports your neighbor breathing. You could be next. So this is a very stressful situation that's avoided with a single bedroom. So what do we take with us to the next pandemic? Will we build with redundancy to handle a future surge? I think in Denmark that's highly unlikely. Square meters are expensive, and the trend is to optimize and make hospitals as compact as possible. I believe in flexibility, and we have, as we've seen in this previous example in Zealand. Will we design more ICUs in the future? Possibly. Will we have a focus on separation of flows? Definitely. And this is something that we can learn from COVID, and where we can help the hospitals be prepared. So I'll end my talk by showing you a project that we are currently working on for the hospital of Norway and Ramboll, in this beautiful site in Norway. It's a new local acute care hospital. The low building that you see on the left is the psychiatry, and then to the right is the somatic hospital, and with the acute care building on the far right. And here's an early rendering of the main entrance. And on the plan drawing, you see this main entrance top left. It looks like it's in the edge of the building, but the psychiatry is not shown here on this plan, so it's actually in the middle. So if you turn left, you're in the somatic wards, and if you turn right, you're at the psychiatry. And then to the far right in this, you see the pink of the drawings here is the acute care, or the A&E. And in the middle, you have this corridor connecting the two wings. Now this is the corridor. Notice the door. It's designed to gain access to common outdoor spaces. It's also perfect for a future pandemic. And the door is placed, as you can see, in close proximity to an elevator that can be dedicated to the purpose when needed. So in this way, we can easily dedicate a whole wing to a new pandemic. You see the pandemic elevator, the elevators going to the other floors, and then of course the acute care elevator. Down at the pink area, the acute care, we are contemplating a new entrance, an extra entrance for triage. Shown here to the right, you have the existing or planned entrances with the blue arrows on top of the plan. But a new pandemic entrance could be useful in a future pandemic. And then a seemingly smaller thing, but still you have to embed it in the design from the start. We are currently adding more sinks to our design. This is hand washing is preferred to the highly flammable hand disinfection. And this is quite interesting because this is sort of an old school thing. Years ago, we designed more sinks, and now they are sort of entering back into our projects, or at least into this one. COVID behind the scenes. The laboratory staff at this hospital were concerned that working with highly contagious substances, they would unintentionally risk infecting colleagues. Therefore, our initial big open lab space to the left has now been remodeled into 2 separate units and a 3rd room for equipment. So for the future, they can use 1 laboratory for the pandemic laboratory. And also smaller separated waiting areas are introduced instead of 1 large common area. As you can see, there's a 2nd waiting area in the back in the rendering. Can we do something extra here? Perhaps it's in the process. So on the larger scale and the smaller detail, if we ask the right questions and use the experiences of the staff from the current pandemic, we architects do have the skills and the tools to help prepare for the next pandemic. Thank you.
Thank you, Birgitte. I have actually a question of my own. You show most of the project that has been transformed in your presentation are newly built. Do you think newer buildings are easier to adapt than the old one? Or have you also seen examples of very old buildings being adapted in Denmark?
In the current pandemic, at Roskilde, they used the old buildings. They came actually prior to the one I showed in Slagelse in Zealand. They found out, they use what they have and what they can do within the premises. And in this older hospital from I think from the 70s, they had 2-bedroom wards, and they found out that this was quite all right for them, because the rooms were large enough to hold a distance from the patients. And what they choose to do was they actually changed within the space within this room. So in the 2-bedroom ward, they could, if they moved close to the door, they could take off all their equipment and PPE, put it in a bag, and then go outside in the corridor. And like that, they had sort of the red room, the contagious room, and the clean corridor. So we don't work with these orange zones as Amy showed us earlier. That of course has means that they change clothes quite often, and they had to wash their glasses, because otherwise they didn't have enough glasses. And so what I talked with the doctor there, could we do something to make sort of a larger zone, so they could use part of the corridor as well, so they don't have to change all the time, and then sort of make this into a COVID zone. So, but it's really interesting is how they use the buildings.
Yeah, definitely. Okay, thank you for your answer. I think we have to go to the next speaker. Thank you.
Thank you.
Okay, then hi again, everyone. Now we'll go over to Annette Pilosov, who will talk from Cambridge, who will talk about some experiences from Israel. Annette, I'll make you the presenter, and I think you should be able to take the screen now. We can see you.
Perfect.
And we can hear you. That's...
Okay, so hello everyone, and really thank you for the opportunity to present to you today with this fantastic panel of experts. And My name is Annette Pilosov. I'm an architect, a researcher, and a consultant for healthcare architecture. And I've been working for a long time, over 20 years, on the topic of planning for change. Really, how can we design hospitals for future flexibility to support change? And one of the drivers, the main drivers of change, is technology. And in this presentation, I'm very excited to present an ongoing research on the implementation of telemedicine for inpatient care in ICU units at Sheba Medical Center in Israel. And I will present on behalf of Professor Michael Barrett from Cambridge University and Professor Ivora Bourne from Warwick University. And it's really a unique collaboration between the UK and Israel, both the Cambridge Judge Business School, the Cambridge Digital Innovation Center, the Center for Digital Build Britain, and the Arc Innovation Center at the Sheba City of Health. So Sheba Medical Center is the largest hospital in Israel, ranked as one of the top 10 hospitals in the world, is located in the outskirts of Tel Aviv. And since the outbreak of the pandemic, the hospital developed through its Arc Innovation Center new models of telemedicine, not only for outpatient care, as we saw all over the world, the great acceleration of telemedicine, but also for inpatient care. The main objective, as stated by the hospital management, was to protect the limited staff from contamination and lessen errors that are related to working in protective gear. The strategy was to increase the overall hospital capacity and provide the best medical treatment for the COVID-19 patient while continuing regular operation as usual. As most of the hospitals in Israel, Sheba rapidly utilized in only a few days an underground parking structure that was designed to serve as an emergency hospital for times of war. Here you can see the layout with almost 400 patient beds divided into different medical divisions, units. And they transformed it into a critical hospital care for COVID patients. And the logic behind this decision was the intent to isolate the coronavirus patients from the rest of the operating hospital units and to save money and time by utilizing an existing structure. The large side of the parking lot was divided into 2 ICUs with distinguished separation of clean zones and contaminated zones and controlled circulation routes. The 2 ICUs have an open ward layout with contaminated zones. You can see Ward A is colored in green and Ward B colored in purple. And both of them have a separate control room in the clean area, which you can see colored in yellow. The control room has telemedicine devices to remotely supervise, communicate, and control the operations of the unit. The units have different models. The control room in Ward A is adjacent to the unit with a big window. That was the photo that you saw right at the beginning of the presentation. And Ward B has no physical view of the unit. They only rely on telemedicine technologies. The staff was divided accordingly into 2 teams, one working in the contaminated zone with full PPE, while the other team supporting them from the control room, and they were all working in shifts of 12 hours and switching every 3 hours. So here you can see really an example how the layout was designed to support the new model of care of using telemedicine as a means to operate, communicate, and really care for the patients. The hospital employed different telemedicine technologies, and Israel is really known as the startup nation, chose to invest in medical technologies and innovation to cope with the challenges of COVID-19. The technologies for remote care supports monitoring, physical examination, management, and audio-visual communication, including video cameras and telepresence robots. Most of the technologies that were implemented at Sheba were not new. Some existed in models of electronic ICU, and others were used for special programs of the hospital to monitor home rehabilitation of patients. And not all of them were implemented in the ICU. In our study of the new model of inpatient telemedicine, we explore the intersection of architecture, technology, and healthcare. So this is really a multidisciplinary research. And by doing so, we really emphasize that the built environment has an impact on the implementation of digital innovation in healthcare services, something that is often not really taken into account, the impact of the built environment on the implementation of new technologies. And we focus on the shifting forms of visibility, a major theme in healthcare design that is transformed by telemedicine and physical materiality. While previous studies focus mainly on physical visibility or on virtual visibility only for communication with patients at home, we suggest to integrate the physical and virtual forms of visibility in inpatient care. We analyze the patterns of visibility that they provide, relationship between users, directors of view, focus, movement, distance, and angle, and examine their implication on the healthcare services, the management of the unit, teamwork and collaboration, and patient care. The research is based on semi-structured interviews of the hospital staff. We conducted over 30 interviews in only 2 months, and this was really significant. The staff was almost waiting for someone to come and ask for their experience. We did on-site observation and data collection of the hospital survey, technological briefs, webinars, and also documentaries on TV, because it was really, there was a lot of interest to know what's being developed in the hospitals. And the interviews and observations really reveal the impact of the shifting forms of visibility on the performance of the unit. For the management, many stated that they were missing an overall perception of the whole wide world that enables them to see everything entirely at every moment. The director explained, "When I make my evening rounds in the regular unit, I can see what is happening in all the rooms in a blink of an eye, as I take a 1.5-minute walk around the unit." The segregated view of the unit on screens does not provide a spatial perception of space, which was found to be crucial for orientation and a sense of control over the unit. It also is missing an integration of the audio-visual technologies and the monitoring systems. And mainly, they simply have a lot of screens to look at to operate the unit. To overcome this limitation of spatial perception, they actually had an innovation. Since they were already in a parking lot, they came with the idea to use a mini car, a closed club car, to drive through the patient's beds and have a better perception of the overall unit. And by using the car, the directors, they didn't have to put on the PPE because it was closed, but they had to drive through a special car washing machine to clean the car when they came out of the unit. The robot was defined by all the staff as the most efficient piece of equipment. The director explained that it provided them the option to move from place to place, to see more than one angle, to distance and focus, while the person on the other side can actually see the face of the person who was speaking to them. They described it as a game changer. The different layout of the wards had an impact on the implementation of telemedicine technologies. Each unit created different models for teamwork and collaboration. Obviously, the staff in Ward B without the window used the cameras and the robot much more than the staff in Ward A. The window was significant for visual communication of the staff, but the acoustic barrier led to low-tech solutions such as hand gestures and handwritten notes. The use of telemedicine technologies also transformed professional practices. For example, here you can see how the physician is using TytoCare, which is a device to remotely examine the patient at home, actually at the bedside, because he cannot hear through the stethoscope covered with the PPE. So here the technology was used as a means to visualize the patient vitals. The new model of care also shifted the distinguished hierarchies of the staff in the medical unit. The head nurse explained to me that the PPE covered any characteristics of the professional role. When help was needed, any pair of free hands came to the rescue. It did not matter if it was a doctor or a nurse. Telemedicine was also used to prevent cross-infection by supervising the staff behavior, to make sure that they are changing their additional cover and gloves when moving from patient to patient. And this is really important to note that usually when the staff move from one patient to another in a regular ICU, they move from one room or one space to the next room, and they go through a space where they can wash their hands and change their outfit. So the built environment supports infection control. But here they only do 2 steps and they're right with the next patients. So really the cameras and the robot help to supervise their behavior. The conception of patient-centered care has changed. The physician stated the challenges of remote care, the frustration of not being able to place your hand on the patient when you give him bad news. But on the other hand, they state, I can be there for them even when I'm not physically present. There was also a lack of privacy for the patient, as the curtains were often removed because of the cameras. A resident doctor shared his concern. In this situation, the conscious patients witnessed the deterioration of other patients. They could see only a few meters from them what they are going to look like in another 3 to 4 days. It was a horrible experience for them. Loss of identity by the PPE was also very significant. And here I would like to share with you a short anecdote. One of the patients who was ventilated for an extended period of time and came to visit after he was sent home, after he was cured, came to visit the staff and to thank them for their care. And they asked him what he remembers from his experience in the ICU. And surprisingly, he said that the only thing that he remembers is the nurse on skates. And the team was really amazed, and they tried to understand what he was talking about. And the director explained to me that probably what he remembers is the robot. It's only the robot. And he explained that probably because all the other staff were people without faces, what he saw was people like aliens covered with masks. And the video on the robot screen was actually the only human face that he saw. And this is, in my opinion, really represent the shift in our conception of the relationship between human and technology. Family support was also a major issue with COVID. At the beginning, the hospital restricted visits of the unit and provided only virtual communication from home or from a special family center that they built especially for the families. But they soon realized that the families needed physical contact with their loved ones. And one of the directors shared his surprise when he recognized that this was also significant even for the ventilated patients. He stated, one patient shed a tear and the blood pressure and pulse of another went up when a family member came to visit them. The location of the COVID ICU in the underground site with no visibility to the outdoors or daylight had an impact on the well-being of the patients and the staff. One of the clinicians told me that it felt like working in a submarine. He stated, I think the staff developed PTSD and high level of burned out because of the underground location. It was caused by the place itself and by the general situation. You cannot separate the two. Another physician revealed that many patients who were not ventilated would beg him to be moved out. And really thinking of similar temporary emergency hospitals that were constructed in Israel and all over the world without daylight or view to the outdoors, I cannot stop and wonder if they will not become permanent solution after so much money and resources were invested in them. And I really believe that when creating a high-tech environment, even if it's high-tech environment, the basic principle of evidence-based design to create a high-quality environment should not be compromised. So what can we learn from this study? I think it represents only a moment in time in the transformation of healthcare systems by advances in technology. Resilience was actually achieved by the implementation of digital technologies for remote care and the affordance of the built environment to support the change. It demonstrates a hybrid model of virtual and physical care, an integration that will probably continue to evolve in the future. The flexibility of the hospital to support change was crucial. Flexibility of the built environment, as well as the flexibility of the organization and the staff to adapt. We have to rely on evidence-based design to maintain quality of space, even in times of crisis. And we have an incredible opportunity and also a responsibility to transform hospital as part of the new healthcare ecosystem that integrates hospital care with community and home care by digital technologies. Thank you really for taking the time to hear about our ongoing research, and a special thanks to the ARC Innovation Center at Schiebel Medical Center. Thank you.
Thank you so much, Nerit. Very interesting also to see how they were dealing with the non-daylight and so on. Do you know if there has been other follow-up studies on the built environment and how they dealt with the pandemic situation in your country?
Other research?
Yeah, or other studies?
Yeah, obviously. There is a lot of things that are being implemented right now, and they are all, I hope everything is being studied. There is, again, like I presented, there is an emphasis on innovation in technology, implementing really a lot of startups, a lot of innovation there. But I'm thinking about how should the healthcare industry, healthcare design industry really have a say in this development? How can we really, drive the change? Because in many cases, the new technologies are looking at the built environment as a given or as a constraint, and we have to find ways to integrate the design process of both the technologies and the built environment. So I'm hoping there are more research in this field. But I have to admit that most of the research that I'm seeing is looking at the integration of the technology with the healthcare services. And not enough work is being done, as I mentioned, on the built environment, on the impact of the built environment and the flexibility of the space to really support the implementation of the technologies.
Thank you so much for your answer. I think we will now go to the poll questions. Thank you.
Okay, then we'll go over to Eduardo Terán from Chile 15 Arquitectos. Eduardo, you should have the control now. We can hear you, Eduardo.
Yeah. Okay. Do you hear me? Yes.
We hear you. We can't see you yet.
No.
There we go. Now we can see you. And your presentation is in presentation mode. Cool. Thank you.
That's perfect. Well, thank you, Michael. It's a pleasure to be here. I would like to start with a short presentation. I'm Eduardo Terán. I'm a Spanish architect. Now I'm architect of Chile 15 Arquitectos. We are a Madrid-based office. The presentation that we bring today is how we are dealing with the pandemic situation in our architectural perspective from Madrid. The building as a tool facing the pandemic, the Emergency Hospital of Madrid. I move on to talk about this building that we are now finishing here in Madrid and is need to face the challenges that the pandemic bring to our society. But I divide the presentation in 3 stages. I make it clear that I will, in a first way, I will talk about a stage 0 about what brings us together here, the history records. Well, in a first stage, how we implement this design of a building, and in the second stage, how we are building it. Because I will take the 3 phases of the design together, so I think it would have a global perspective of what is happening now. Well, stage 0 is what is happening now, the COVID-19 crisis and immediate actions. It's important to say that, well, the COVID crisis came to us. The administration of the regional government of Madrid, the Community of Madrid, and the healthcare department brings the idea to use a big building that we have here, and it's a pavilion typology, to use and to implement as a temporary hospital. Well, this kind of building is called IFEMA. IFEMA is a building provided to fashion, to commercial events. It's a very big building that we have, and the first idea was, well, we could use this building as a temporary hospital. Well, the Madrid IFEMA Exhibition Center is the faster location to set up a building response. We have several pavilions, we habilitated some of them, and we have 2 key points in order to achieve this kind of typology, a proper hospital response. Well, one of the key points was the existence of a large volume of air in different spaces, because when we have a big hangar, we can move a lot of air, and we can organize in a better way what are we designing, what are we providing as our response to the COVID crisis. As well, the modular organization. If we have no walls, if we have a plain building, we could organize very well, and we straightforward all the pathways and all the programs to come together. This is one of the, I don't want to spend a lot of time with this because we have a lot of things to talk about, and I want to not to left some of them out. But this is one of the images of this building prior to the coming of the COVID crisis. We put the building completely clean without removing all the walls it had, and after a work of days, I wouldn't say a week or pair weeks, the building has this form. We set up all the hospitalization areas and all the modules where all the people came. Some people came here to this building in order to reduce the increased demanding of hospitalization in the hospital of Madrid, because we have the problem that we are not able to support all the patients that came into the hospital. So this building is in other ways a tool. Well, we can move this patient here, and they could have the proper attention. This is a floor plan of the building, which I think is very representative of what are we talking about. It's a scale of, I would say, at airport scale, maybe. The pavilions that we set up were 7 and 9, and at the end only 9 was used, because it was a good new for all the society that we didn't require the use of the rest of the pavilions. But it was the very first effort that we made, not only at architectural studio. This project involves a lot of companies, a lot of people, public agents, estatal agents. So it was like the first step we made against the COVID. But something happened when we were in this line. This building is not private, and is a private and public mixed-use building. So we couldn't use it as a temporal hospital forever. It has its own agenda, so we need to do something extra. And it comes to the table the idea of, well, we could make a building replicating this model that for all people works well in terms of design. Yes, the idea was, well, we are going to make a building that could use as a permanent infrastructure against the COVID crisis or future pandemic situations. As well, we are going to implement with the other uses that we need. For example, material and logistics, as well as office and administration. So it came the idea to make this hospital an emergency hospital in Madrid called Isabel Zendal, was one of the first nurseries of Spain in history. And what are the needs of this building? Is, well, as a result, in response to the need of detecting after the COVID-19 virus, with particular relevant impact on the city of Madrid, we promote a building to dispose for future emergency situation coordination. That was one of the main key points of the next phase of design of this building. Coordinate all the action that in Spain we have several administrations, so it's important to have a point to coordinate all the action to hospital, society against these situations. As well, as I said, the complex will work as hospitality complex, but as well it will have material and logistic reserves. This is one of the very first sketches of the idea of the project. It was one of the very first idea came to the ground, but we have to. I would like to set up a little bit idea of what is happening with the project. Well, for people who are not used with the city of Madrid, this is the city of Madrid, and this is the airport. So the strategic location of the building will be here. It's a new place, development area, and it's very close to the airport. It's very close to the connection with the city. So it was like a good place to start thinking design for a hospital. It happened something. This is the the presentation. This is something very. This is the floor area that the plain area where the building is going to be fit. This is our site. So the building is going to be, it's important to say that there was a pre-existence previous project set up for this place that I don't want to spend time explaining it, but it was like a city of justice for administration. And there was a gallery and some tunnels here, so it was some difficult works in the other foundation, but as I said, I don't want to spend time explaining this because it's very complex, but it's only to say that this is our site, and this is one of the buildings of this previous complex that is built. This is Alejandro Zaera building, one office for administration that now is integrated in the new hospitality complex. Well, which are going to be the definitions of our design? First of all, the definition of a module. We are going to work like cells. This is very important in how we live, how we see, and how we think this kind of buildings. A modular cell that brings together a common set for the building is going to give us the modular construction versatility, so we can implement different agents, private agents and contractors in order to speed up the construction of the building. And we are going to differentiate the pathways. The pathways are fundamental in this kind of hospitality areas, so we could separate the personal circulation, and we move these cells. We could have a easy model to respond. That was one of the main tasks, is to set this kind of building. This is one of the first drafts of the building. As I explained before, we started from this hangar scale, this large pavilion scale. We bring together the hospital in this way. So we are going to have 3 pavilions that are separated in different cells with the hospitality beds and some intermediate and intensive care units. As well, we are going to provide an office administration building for the regional government of Madrid. We are going to provide a storage and facility area to relocate and to hold all the clinic material that Madrid is gathering in the city for future crisis or for this pandemic crisis. And we are going to have some buildings for energy. This is the building that I explained you before, one of the Alejandro Ferra buildings of a previous complex. And we are going to integrate this in the whole complex of hospitality. Well, this is a previous draft of design, but I think it's not very different from what comes now, which of course there are some difference between one phase of design and the execution that we are now in hands. But I think it's very important to separate the concept. We have a building that is joined with which has a connection with an administrative department. We have a public street that will connect with all the people that we came to the building. We will have an access with the ambulance and all patients, and we will have a logistic world that will be underground, and we have a separate role. This is one of the very first renderings we did for the complex. In order, you see at the back, the city of Madrid is really close to the city, and you can see in the front line the hospitality complex as well, the administration volume, the material and logistic at the back, and one of the central energy buildings that nowadays is moved forward. But I think we want to preserve this idea of a big building, but with the optimal scale to have this kind of pavilion. So it's not seen as a common hospital, but it has the advantage of the buildings for fair and exhibitions that we have in Madrid and there are in many other cities. Well, now I want to go to step 2, where we are going to talk about how we build this, or how we build, well, is how the process that are taking shape in order to bring this building to reality. The construction of emergency hospital. Well, we start this process in May, finish in May, June of this year, and the challenge for all the contractors and architecture studios and all the agents is to set up the building in less than 6 months, maybe 5 months. So in a period of time of 4 and 5 months, no more, we have came back from this sketch and these primarily ideas to a fast track condition. Well, it's important that this is one of the main movements of this project of main support. We are in a fast track. The main idea of the fast track is we build what we are designing at the same time. So there is no time to make a large period of design. We have to implement it very fast. We have people waiting on the construction site for our design. So there is a close relationship between all the contractors and between all the designers, which it involves that the building has a kind of life spirit that is happening on site, what is being designed some hours before. So there is a challenge of we are going to build something without mistake in a short period of time. This is a high pressure design that involves a necessity to regularize and to normalize and to think the whole complex as a cell units in a very easy, affordable parts. Well, I want to stop here a little bit. This is the main floor plan of the building. As I explained before, we have here the main 3 pavilions of hospitalization. One of the third pavilion will be in reserve. It will be operational if it's needed in more time, but nowadays it's just being completed, but will be in ground floor empty. These are the other building, the administration area. We have here the storage and the facility complex. As well, we have here the central energy system with heat killers with heat. Sorry, that bring heat to all the complex and to all the buildings. This is the Alejandro Ferra buildings. One of is integrated now in the whole design. The hospitalization areas are here in green. That we plan the ambition of the community of Madrid, a building for 1,000 beds, 30 beds, and we provide these big spaces for all these hospitalization units, as well one part for intermediate and intensive care units. These are the communications marked in red. We have this combine of two pathways where you can see the old corridors and some special and reserved space that brings services to the main area that you can find here in blue. We have a basement, so the basement is necessary in order to accommodate all the installations and facilities and some kind of infrastructures, and always gives service to the main building, as well as some part of the basement is dedicated for the staff. And we have, I won't say a first floor, it's just the main level. The first level is just a corridor that brings some administration and some other uses, but we have emptied these places, so it's not that we have two floors in reality. Well, when I was talking about design, it implies all agents. So at the same time we were designing the building, we were calculating the building, and we were detailing the building. So once the building and the foundation and the structure is designed and we have the approval, we start solving everything that is coming in the works, in the construction site. Because as well we are designing, we have to resolve some details, but we have not the time to resolve the details in our studio as a normal project. We don't have time, so we have to be in the site. It's implied different kind of register of drawings. We have sketch, we have BIM models as well. Everything comes here and some on the construction. So the main goal, or I would say the main challenge of this project, is all this previous effort that we are doing and all the people that coming together came in the idea of building the building in time. It's not only a matter of administration, it's a matter of reality that the society needs this building, because we have no time to waste against the pandemic. We have a high pressure now in Madrid. In time, this building will make a solution in order space to make this hospitalization area more functional and to provide space to reduce the impact on the rest of the hospitals in the region.
Eduardo, Michael here. I can see you have many slides still, and we have already a couple of questions. So could you wrap it up in 3 minutes, maybe? Thank you.
Sure. I finished, yes. Well, as I said before, we have modular and self-design. The project Relocate is kind of, we have to have an idea of the RCSF with 84 patients, intermediate care, intensive care. We have also provide a device circulation system as well. We have a public street, we have the green corridors, we have the dirty corridors here when the ambulance and patients came here, we have the logistic, and we have some corridor for the staff. Well, some point of this is the biggest part of the late part of the presentation. It's important to remark the industrialization and steel construction. It's impossible to achieve this kind of building without having the tools and with having the contractors in order to keep this building in time. We are working here with 14 companies, and the hospital building is with 3 building enterprises. I want to share some photographs of the construction site. We were assuming all this work together, the steel structure as well. As well, we are doing the steel structure. Something is happening in the basement. So we are finishing the basement, we are making the structure, we are building the other part of the building. it represents very well the idea of fast construction and fast design. We have no time to lose. And of course, with the facade, when we have this idea of we have this glass perimeter and we have the facade on a steel facade on the top. We have this, of course, involving facilities of energy renewal. We provide a building that is summing all these efforts together. As you can see here, we are finishing this building structure with the slab. We have this part yet finished, and probably tomorrow will be complete. Another image that represents very well what I'm telling is the idea of we have some part of the building finished in a way, and we are building the next one, so everything happening at the same time. We are very fast in a way to achieve the goal. We start in June of this year. This was more or less the area of making the slab, and 4 months later, we can assume that the building is almost complete, and we expect to finish it in this month. And this is many thanks for all. Thank you very much. Yeah, I know this is a little bit in a rush, but I want to explain a lot of things. Thank you.
Thank you so much, Eduardo. It was a very interesting presentation, and we got a lot of questions both on the chat, but I also got on my private Slack account here, people that have been asking questions that I should ask you. Unfortunately, we don't have so much time. I might email you some questions after, and maybe we can share with the audience. Thank you.
Thank you.
And now we go to the poll questions.
Okay.
Thank you.
So hopefully now we will have, thank you, Eduardo. I will just try to share my screen. There we go. Show my screen. And can you see we've got this Mentimeter working now? Can you see it? Yeah.
Yes.
And I guess we'll just start with an interest of sort of also finding out who's interested in this project. I would like to ask you if you just take out your phone now and go to menti.com and use this code, and then we'll just try to get an overview of what kind of, who has an interest in this work that's being done. So if you can take the time just to go and identify what kind of organization you come from, that would be very helpful to also to identify the stakeholders. We'll take a couple of minutes. And Mika, I guess I will hand it over to you to sort of sum up the things. Mika, are you there? I think so.
I am. So let's just go back to the poll.
Oh, sorry for this. It's doing all this. Okay, sorry. This is a bit confusing with too many people. There we go.
We go.
We got the poll, right?
So exactly, we're on it. We're at 35. So let's aim for 60, 70 answers. The precious presentations don't cost you anything except 4 answers in these surveys. That's all it takes. Let's see. So there's people who are looking for the code. I'm posting it again in the chat, just a second.
It is on the top of the screen now. It should be. I can see it at least.
Here we go. Still waiting for a couple more. All right, then let's move on to the questions for after the presentations.
Sorry, it's going to be a little bit, make sure I won't miss anything. Here we go.
As usual, I can already see some people already answered on some key takeaways throughout the presentation. We have already 36 people doing that. So those who haven't answered yet, you can add a couple points. What do you take away from these 4 very diverse and extremely interesting questions, presentations, ideas, inspirations? So let's go over 50 responses.
One more.
A lot about flexibility, technology, evidence-based design, I think, is something we heard a lot. Very good, X3. Well, so then let's go to the last question. So as we said, we will include these case studies and many others from all over Europe in our field guide that we are actually planning to release at the end of this year. We are also thinking about after the last webinar that is scheduled for end of November. Fleming will just talk about this in a second. We plan to have one where we actually release the field guide together with the audience. And the question here is really very openly, if you think about resilience from staff, systems, space, or other perspectives, what would you like us to deep dive more in the future work? It's really also here to give your kind of wish list for the field guide. What would you like to read more about? The more specific, the easier for us. Also, you will see our contact details at the end of these presentations. All of us are open for suggestions and interesting case studies. Also, if you happen to see a case study in a language other than German, English, the Scandinavian languages, Italian or French, forward them to us so we can Google translate them and include them as well. 1 or 2 Finnish cases would be still great that we're still looking for. Other than that, we have a lot of countries covered already. Eastern Europe, I think we also have some inputs already, but we can always have more. Very good. as I understand now, Fleming, you will wrap up the webinar. Maybe we have time for one or two more questions as well.
Yes, I think there should be time for a couple of extra questions. I don't know, Saga, did you pick up on those, or if we have the time, we can do that. But otherwise, we would like to put the attention to our next webinar on November 17th, as Misha just mentioned, where the focus will be on the healthcare ecosystems. But yeah, getting back to you, Saga, do we have some extra questions that we would need to address now, or?
Yeah, I think we got some interesting questions, especially for Eduardo, who didn't have any questions in the end. So I can start with one question that I got. They ask, how do you plan to staff this hospital? From other hospitals, or is there another way of doing things? Is Eduardo here?
Yes, Sarah, yeah. Could you repeat, please, because I was muted?
Yeah, the question was about staffing. Like, where does all the staff comes from? Do you have a lot of healthcare staff?
Oh, hi, okay. Yeah, well, the healthcare staff came from new contractors, new contracts that I assume that the healthcare department of the Community of Madrid will make. But of course, you will have a primarily engaged of people or workers from other hospitals. We are in these terms, as architect, I think it's more an issue of administration that properly an issue of design. I believe that there will be a negotiation and there will be a coherence between all the agents involved, but I think the building will be kept. Of course, there will be an effort to make from all the parts. Administration are always the people that are working on the main hospitals.
Okay, thank you for that answer. I have another question here also. The person who asked, I wanted to know if this building is planned to be a future hospital after COVID outbreak, or if it can be changed to other functions.
Well, this is a good conversation because we always have that. Well, we will leave this building as a public service building in future. So now it's for the pandemic of the COVID crisis, but in time I see the building, this could be an hospital for, I don't know, for some other catastrophes or some other incident that we have. I believe the strongly point of the building, one of the main key points is a logistic and material supporter for all the community and people that we live here, and also provides a wide and alert space that, as I started my presentation talking about IFEMA and this pavilion, that we couldn't use all the time. Some people, sometimes we think that we could use all the buildings that we have in the city, but it's not the reality. We need to provide some new buildings. So I think it will have its own role as well as a public service.
Okay, thank you. I think I will leave it back to you, Fleming. You also had a question, right, to Eduardo?
Oh yeah. Eduardo, I had a question on my own. I was wondering, assuming that this process of fast track is new in Spain as well, how did key stakeholders, like for instance the contractor, how did he receive this process, and how do you handle risks in terms of this?
Yeah, well, there was a first step that was an invitation from the administration to all the contractors in order to keep all people in line and to keep all the schedule and to organize all of them. And well, that was something that is really important, that we have a stream coordination all the time, because there was the key factor that the time you move a wall, the time you move something in the plane, you have to report it. You have people that are going to call you that what happened to the building this specific time. So there was a, it's like we are working together all the time, that we are not isolated in the studio. We have some kind of course, I'm going to share my webcam, that we are not isolated, we are together. And this, I think, is the key point of these happenings. It's impossible to imagine this building one per separate and with some meetings in 15 days. No, we have meetings every day. We have a strong relationship between people that are working on the area and contractors and all the agents involved in the work.
Okay, thank you very much. Well, I think we're at the point where we should wrap this up. Michael, if you go to the next slide, just giving you a short status on, oh, that's not the one. This is still the Mentimeter results. Okay, I think you should go one further. Yeah, just giving you a status on where the project are right now. As Misha just said a little about, we are right now under preparation of the field book, meaning we are working on it. We are analyzing and doing the initial steps on it. And as Misha said, we really need all the inputs from you guys out there. So please, if you have something that you think might be interesting, please reach out. We would be really happy to get more cases or ideas for that matter. As stated earlier, we are building a website for this, where we will share all the knowledge, the field book, and hopefully the cases as well, with your consent, obviously. We will do the presentation of all the work during the final webinar, as mentioned, by the end of the year. That said, we are also looking at ideas for further development of this project and even more webinars. So as in the Mentimeters, please, if you have some more ideas on this, get back to us as well. Yeah, that's just about the situation for now. That said, I'd like to thank you all for attending, and most of all our 4 very interesting case studies and presenters. It was really a pleasure having you all here today, and we really hope to see you again on the next webinar in November. Thanks a lot, and have a nice weekend when you get there. See you all. Bye.
Thank you very much, everyone. Bye.